time to start. So my name is Egina Francis Makwabe. I am the consultant physician and nephrologist working with AHN, Africa Healthcare Network in Tanzania. I would like to welcome you all, the participants from all over across Africa and outside Africa. So today's topic is management of malnutrition and protein energy wasting among patients with kidney disease. So we'll be focusing on outcomes and current guidelines. So it's a great honor and privilege to introduce to you our today's speaker, Dr. Michelle Wong, who is a clinical assistant professor from Department of Medicine, University of British Columbia, Vancouver, Canada. And she is a nephrologist and clinical research at British Columbia, Vancouver. She has done hemodialysis research fellowship and renal research at the Renal Research Institute, New York, USA. And she had worked with DOPPS. DOPPS is dialysis outcome and practice patterns program at Arbor Research Collaborative for Health at Ann Arbor, USA. So she is also an inaugural cohort of International Society of Nephrology Imaging Leaders Program 2021. So Dr. Wong, you are warmly welcome, and the floor is yours to take us through today's topic. Karibu.
Great.
Yeah.
Thank you so much. I'd really like to thank the organizers and especially Dr. Vincent and Nick Pereira-Kameth for inviting me to give this talk to you today. So this is a topic that's very current area of research for me. And so I hope to shed some insights on the guidelines and our oral nutritional supplement program. Okay, so my disclosures, my funding is through the Michael Smith Foundation for Health Research. And so the objectives for today are to provide an overview of outcomes associated with nutritional management in protein energy wasting. I'm going to focus on oral nutritional supplements, intradialytic parenteral nutrition, and intraperitoneal amino acid supplementation. I'm not going to be covering appetite stimulants, growth hormone, or anabolic steroids, but I'll be focusing on the KDOQI, which stands for the Kidney Disease Outcomes Quality Initiative Clinical Practice Guidelines for Nutrition in CKD, which were released in 2020. And this is an update of their guidelines, and I'll be focusing specifically on assessment and management of malnutrition and protein energy wasting. And the reference for that guideline is on the bottom there. Okay, so first, I'm just going to give a background about malnutrition and protein energy wasting. So nutritional and metabolic alterations often coexist in patients with chronic kidney disease. And I wanted to define two terms. The first, malnutrition, and what we're really referring to is undernutrition as opposed to overnutrition. And this reflects predominantly a loss of fat mass, and it's a consequence of insufficient nutrient intake. And I want to contrast this with protein energy wasting, which we'll abbreviate as PEW, which is a loss of body protein stores and fat mass. And this has also been referred to as protein energy malnutrition or uremic malnutrition, but the proper term to use is protein energy wasting. And it has a lot of factors contributing, including not only nutrient intake, but also inflammation, metabolic derangements, and comorbidities. And in the setting of CKD, protein energy wasting is of central importance. Here we see these complex interactions and consequences of protein energy wasting in kidney disease. So on the top, you see the gray boxes there, which are the causes of protein energy wasting. And these include the uremic milieu, the comorbidities, the metabolic derangements, hypercatabolism, protein losses in dialysis. And note that many of these factors are related to inflammation. In the green boxes below, you see the consequences of protein energy wasting, and these include increased risk of mortality, hospitalization, decreased quality of life, cardiovascular disease, as well as abnormalities in lab parameters and body composition markers. So in the non-dialysis CKD population, the prevalence of protein energy wasting has been assessed in a systematic review, and the range was 11 to 54%. And this is just based on 5 studies that had significant heterogeneity. This includes Netherlands, Australia, and Brazil. And as the eGFR declines, the risk of protein energy wasting due to metabolic disturbances or uremia rises. And we also know that there is a significant decline in weight and BMI after the eGFR decreases to less than 35. And that has been shown here in the graph with 2 US-based cohorts. Now, at the transition to renal replacement therapy, nutritional status is also a very important prognostic factor. So we know that early mortality after dialysis initiation is high, particularly in the first 120 days after dialysis initiation. And malnutrition and hypoalbuminemia are potentially modifiable determinants of this risk. And you see on the right here is the high mortality rate in the first 120 days of dialysis, which is consistent across multiple countries. And we know that patients with more than 5% weight loss before dialysis initiation have a much higher risk of death after starting dialysis compared to with patients who had stable weight. As well, we know that nutritional status tends to be lowest at the time of hemodialysis initiation. And this was based on some research that I had done at the Renal Research Institute. We did a study where we took a composite of many nutritional indicators and looked at them over time from the start of dialysis. And we see that they start at the lowest point at dialysis initiation and then gradually improve and plateau in the first 2 years after initiation. Now, in terms of nutritional status in dialysis, the same systematic review that looked at prevalence in the non-dialysis population also looked at the dialysis population. And their interquartile range for the global prevalence of protein energy wasting was 28 to 54%. And I note that in definitely protein energy wasting is more prevalent in end-stage kidney disease compared to non-dialysis. But there is data lacking in many regions of the world. The areas that are in white here do not have any data. And I note that in sub-Saharan Africa, we have data from Nigeria and South Africa, which demonstrate a very high prevalence of protein energy wasting, about 55 to 58% of dialysis patients. And I know there's some new data coming out of Tanzania from Brahmania and colleagues. And so it was published after this systematic review, so I've just added it in here. And I understand that the prevalence of protein energy wasting as defined by malnutrition inflammation score is about 46%. And then using a different type of composite indicator, the subjective global assessment, the percentage of patients with malnutrition is about 61%. So definitely a very high prevalence in sub-Saharan Africa. Okay, so moving on to the KDOPPS guidelines, just some background information. They were meant to give global evidence-based guidelines. They were developed jointly by the National Kidney Foundation and the Academy of Nutrition and Dietetics with an international working group. The evidence review focused on adults greater than 19 years old with CKD stage 1 through 5, including dialysis and transplant. And the literature covered in their systematic reviews was from 1985 to 2016. And note that they graded their recommendations based on the quality of evidence, ranging from high to very low, A, B, C, D. And as well, they've graded the strength of the recommendation, 1 being strong and 2 being weak. Now, the scope of these guidelines is quite vast. It includes macronutrient, micronutrient, and electrolyte topics. Within these topics, they've covered assessment, intervention, and monitoring. So I encourage you to look at these guidelines. What we'll be focusing on today is really the protein energy wasting aspects of the guidelines. All right, so in terms of how we assess nutritional status, there's no single measurement that provides a complete assessment of nutritional status. So on the left here, we have serum chemistry, and then dietary intake, and then body mass and body composition markers. For serum chemistry, it's important to note that there are many caveats to interpreting serum chemistry markers. They're often influenced by non-nutritional factors, including inflammation, volume status, albuminuria. For example, serum albumin, it's strongly associated with hospitalization and mortality, but the guidelines do stress that albumin alone is not a good indicator of nutritional status. It is important to keep that in mind, that they must be interpreted in the context of many nutritional status indicators. All right, and there's dietary assessment intakes, either through food diaries or food interviews with dietitians, interviewing patients, food frequency questionnaires. We have body mass, which also it's important to consider the change in weight over time. And then for body composition, these often require technical measures, and so perhaps they're not commonly used in day-to-day practice, but they can be very helpful. These include mid-arm circumference, skin fold thickness, hand grip strength. For bioimpedance, they recommend multi-frequency bioimpedance. And the gold standard for body composition is the DEXA. There's also other imaging strategies, but DEXA is considered the gold standard. And then the bottom here, you see these nutritional scores that I've listed here, the subjective global assessment and the malnutrition inflammation score. We'll go through those in just a moment. Now, the International Society of Renal Nutrition and Metabolism has developed criteria for diagnosing protein energy wasting in chronic kidney disease. And so they've taken these 4 categories, serum chemistry, dietary intake, body mass, and muscle mass, to develop specific criteria cutoffs. And note you need to meet at least 1 criteria in 3 out of the 4 categories below here. And so the sensitivity for picking up protein energy wasting using this, these criteria is low, because these criteria are very strict. So in research, they do often use the composite nutrition scores, like malnutrition inflammation score or the subjective global assessment, to actually diagnose protein energy wasting. Now, here's a few key guideline points about the anthropometric measures that were mentioned in the KDOQI guidelines. Specifically, low BMI predicts mortality, but in isolation, it is not sufficient to diagnose protein energy wasting unless it is very low, less than 18.5. Secondly, the percent change in usable body weight or dry weight in hemodialysis may be more reliable in determining risk of protein energy wasting than the absolute weight or BMI at a single time point. And thirdly, technical measures like bioimpedance and DEXA, due to their cost, there is insufficient evidence to suggest using them on a routine basis in clinical practice. And I'd have to say that in British Columbia, although we do have these measures available, they are not used on a routine basis. And increased abdominal fat deposition, there's a marker called the conicity index, which can be calculated from waist circumference. It has been associated with increased risk of protein energy wasting, inflammation, and mortality in hemodialysis patients. And this reflects possible obesity sarcopenia, in which people have high adiposity but low muscle mass. And this also points to the first bullet point here, that low BMI is not sufficient to diagnose protein energy wasting. You can still have protein energy wasting with a higher BMI and high adiposity and abdominal fat deposition. Okay, now I'm going to go back to these composite nutritional indices that I mentioned. So for the subjective global assessment, they recommend using the 7-point SGA as a valid and reliable tool. And this is graded as 1B evidence. And then the malnutrition inflammation score can also be used, and I'll go through those right now. So this is an example of the subjective global assessment, 7-point scale. Traditionally, it was developed as a sort of semi-quantitative 3-category scale, but this is a more quantitative version, and it's been widely used and validated. And the 7-point score has been able to distinguish different degrees of protein energy wasting that are associated with increasing risks of mortality. So that's why they selected this one as the optimal SGA version to use. And then the malnutrition inflammation score here was developed by Dr. Klanter-Zeta, and it is an evolution of the subjective global assessment. So the first 7 questions here refer to the subjective global assessment components. And then they've also added body mass index, serum albumin, and total iron binding capacity. Okay, so with respect to screening for identifying patients at risk of protein energy wasting, they recommend routine nutrition screening at least biannually. And a lot of dietitians would do this more frequently. And the nutrition screening tools, they really said there's no evidence to suggest one tool over another. So this screening might include questions about weight loss over time, or dietary intake being less than usual. There might be just screenings of weight change over time by the dietitian or lab parameters. So there's no specific tool recommended, but just to say that these screenings should happen at least biannually. And so a routine nutrition assessment, they recommend a registered dietitian nutritionist should conduct a comprehensive nutrition assessment at least within the first 90 days of starting dialysis, ideally as quickly as possible after starting dialysis within the first couple of weeks, but at least within 90 days of the initiation. And then annually, or when indicated by nutrition screening, or if there's a change in status, such as a recent hospitalization. And in terms of the comprehensive assessment, what does it include? It may include any of these things here, including weight, diet history, biochemical, anthropometric measurements, physical findings. Also listed here, dentition, food security, physical activity, and then those 2 composite nutrition scores that we mentioned, the SGA and the MIS, also very helpful for assessing nutritional status. All right, so now we're just going to move on to the interventions. And this is an important slide that identifies the progression of nutritional interventions. So first of all, dietitians will always start with nutritional counseling. And when that alone is inadequate, oral nutritional supplements can be added. And then if that is inadequate to meet the patient's needs, enteral tube feeding can be considered. And if the enteral route fails, then you move on to the intradialytic parenteral nutrition or total parenteral nutrition. So it is a stepwise process. And with respect to nutritional counseling, these are some of the guideline recommendations here for intakes, for energy intake, as well as for the dialysis population listed here, the dietary protein intake. And I encourage you to look at the guidelines for intake, which we won't specifically cover here today. So their recommendation with regards to oral nutritional supplements that patients who are at risk of or with protein energy wasting, they recommend a minimum of 3-month trial of oral nutritional supplements to improve the nutritional status of patients. And this comes from the studies that were included in their systematic review. Now, the types of oral nutritional supplements that were covered in the included clinical trials in their evidence review include what they call a ProteinEnergy ONS, which are general oral nutritional supplements that have protein, carbohydrate, and fat. And there are general ones, there are renal specific ones that tend to be more energy dense and have low electrolytes in terms of potassium and phosphorus. These are some of the commercial products that are available in my home province here in British Columbia. There are specific ones for patients with diabetes as well. I note that in some of the studies, they use specifically energy-based ONS, and those tend to be maltodextrin or glucose polymers. Those are ones that don't have protein in them. And then there are other ONS, which are protein-based. And so this is just an example here of commercial ones. All right, so in terms of outcomes for assessing oral nutritional supplement use, the clinical guideline committees focused on randomized controlled trials and non-randomized trials as well. And their specific outcomes of interest were mortality, hospitalizations, and quality of life. But I do note that there's a lot of surrogate outcomes that are studied in these trials as well. And so they've included biochemical markers, body composition markers, and other outcomes as well. But this just gives a framework. And in terms of the overview of ONS trials, there were 12 randomized trials and 3 non-randomized trials included in their evidence review. Most of these studies focus on maintenance hemodialysis, which is abbreviated here as MHD. There was one study that combined HD and PD patients together. In PD, there were 2 PD only studies and 1 study of both HD and PD here. And in the non-dialysis population, just 1 study and none in the transplant population. Most studies examined commercial oral nutritional supplements, and some studies enroll patients with malnutrition at baseline, but there are a number of studies that did not actively enroll malnourished patients, so they did differentiate those. And it's also important to note that most studies utilize a comparator of no oral nutritional supplement or standard care with dietary counseling only. These studies are rarely placebo-controlled, and the duration of these studies was 3 to 13.5 months. So there is only 1 study for oral nutritional supplements in the non-dialysis population. So I can highlight that here. The study was 129 patients in stage 3 or 4 CKD patients with a low protein diet. They did not select people for protein energy wasting. and they gave a 200 kilocalorie non-protein calorie supplement versus dietary counseling only. And they were able to identify a lower urine protein excretion throughout the study, and people were able to adhere to a lower protein intake diet. There was no change in other lab parameters such as albumin, CRP, or lipids, or weight. And we don't have any data on hard outcomes from this study, including mortality, hospitalizations, and quality of life. So this formed the basis for the research that I've been doing at BC Renal. We've been looking specifically at this population because we have a program where oral nutritional supplements are given to patients regardless of their EGFR. And so that gives us an opportunity to look at outcomes in this population where we have a lack of data. And so in the dialysis population, the mortality outcome was assessed in one clinical trial, or it was a clinical trial, but non-randomized. There were 470 patients on hemodialysis with low serum albumin, and they were given a general oral nutritional supplement until reaching a 3-month mean albumin above 38. And they were compared with patients who met indication for ONS, but ONS was deemed inappropriate or it was refused. The median duration of the study was 13.5 months. However, they did not find any difference in mortality in this study. For the hospitalization outcome in the dialysis population, there are 2 RCTs and 1 non-randomized study. So the first study here at the top by Wilson, small study of 32 HD patients with hypoalbuminemia, used a general ONS, followed for 9 months, and had no difference in hospitalizations. And similarly, the study by Moretti, 49 patients of both hemodialysis and peritoneal dialysis, didn't actively recruit for malnutrition. They used a protein supplement and compared to no supplement for 6 months, and then did a crossover study. There was no difference in hospitalizations as well. And these 2 studies were likely underpowered, but pooled together, they did not find a significant difference in this outcome. The non-randomized trial, however, was larger. It was 470 patients, and they did find a reduction in hospitalizations associated with oral nutritional supplements with a hazard ratio of 0.66. And that's the same study that looked at mortality in the previous slide. Now for quality of life, I just point your gaze over to the little figure here of the SF36. And this is a questionnaire that covers 8 domains of health. And these are grouped under physical and mental components here. So there were 2 RCTs, one from Brazil, small study of 18 patients. They studied a general oral nutritional supplement, which was actually non-commercial, and they gave the ingredient list and directions on how to make this oral nutritional supplement. And they compared it to dietary advice only, followed for 3 months, and found improved scores for physical role functioning and bodily pain. The study in Europe here, a bit larger, studied patients also with mild malnutrition and gave a renal specific oral nutritional supplement and compared with standard care, also followed for 3 months. They did not find any statistically significant difference in any of the SF36 scores in any domain. In the intention to treat analysis, that they thought that this may be due to the fact that there are a lot of patients who are non-adherent. They did find an improvement in the SF36 scores among patients who took the supplements in the protocol analysis. And then the non-randomized trial, there was one study from the US that looked at a renal-specific oral nutritional supplement given at the time of dialysis, compared it with patients who did not wish to take oral nutritional supplements, and they did find an improvement in physical role functioning. However, when the Guideline Committee pooled results, they only pooled results from the randomized studies, which I think is appropriate, but they didn't find any significant difference for any of the domain scores for quality of life. Most studies looked at biomarkers, especially serum albumin. And so this is just the forest plot here of a different publication here, which did a meta-analysis. And I just note that there is an improvement in serum albumin of 1.58 grams per liter identified in this meta-analysis, but there was significant heterogeneity, so we should interpret this with caution. So in terms of the remaining outcomes, these are slides from the National Kidney Foundation. And so with regards to the composite nutritional scores, there's one RCT, they did show improved SGA scores. One non-randomized trial did not show any change in the malnutrition inflammation score. As mentioned, oral nutritional supplements do improve serum albumin levels, and most of the studies assessed this outcome. There was no effect on pre-albumin from one clinical trial, mixed effects on total protein, no effect on transferrin. In terms of anthropometric indices, there was mixed results. Overall, no effect on BMI, but when they looked specifically at studies with energy-based ONS, there was increased BMI. There was overall increased body weight, no effect on dialysis target weight. There was a significant increase in lean body mass or fat-free mass, and a significant increase in skin fold measurements, but there was no effect on arm or muscle circumference. And moving on to intake, there was increased protein intake and normalized protein catabolic rate overall with using protein-based supplements, but for energy intake, there was increased energy intake overall in hemodialysis patients. In the non-dialysis study, there was no increase in energy intake. There was no effect on phosphorus or calcium, and no effect as well on CRP, anemia markers, and other electrolytes identified in these studies. So overall, this gives us a snapshot of the evidence for ONS use in dialysis. Most of the studies for ONS are in the dialysis population. And while studies have demonstrated benefit in biochemical weight and body composition parameters, the effect on hard outcomes such as mortality, hospitalization, and quality of life has not been well established due to underpowered RCTs. A mortality benefit has been suggested by a few observational studies, but this has not been borne out in the clinical trials. So there's some implementation considerations that the KDOQI guidelines mention here. First, ONS should be prescribed as needed to maximize calorie and/or protein intake to meet the daily energy needs. So it can be prescribed intermittently, such as on dialysis days, when patients are more likely to eat less due to a missed meal, or up to 3 times per day as needed to meet their requirements. And they recommend patients should be advised to take the ONS 1 hour after meals rather than as a meal replacement to maximize the benefit. And oral nutritional supplements come in so many different forms, whether it's a drink or a powder or a bar. So the prescription should take into account patient preference and available resources. And then, as I mentioned, renal-specific ONS tend to be energy dense with low electrolytes, and they might be necessary to avoid fluid overload and electrolyte derangements. Monitor provision of high protein meals during dialysis or ONS during dialysis may be a useful strategy to increase intake. And the provision of a high protein diet was the subject of a trial called the FREDI trial, in which they compared high protein meals during dialysis compared with a low protein meal during dialysis. And they did find that there was an increase in the albumin while still keeping the phosphorus within normal range. And note the intervention also included lanthanum carbonate here. And so I'd like to hear about your practice as well, like in terms of do patients eat while on dialysis? This is a topic of a bit of controversy, but certainly there does appear to be some benefit for a high protein meal during the dialysis session. Now, there are future areas of research that need to be addressed in terms of the specifics of the ONS therapy. There are a lot of questions that were not addressed in the guidelines because of lack of evidence. And so we definitely need more research. So in terms of who benefits most from oral nutritional supplements, should we give it to all patients or just higher risk patients? When should we give the supplement, before or during dialysis or in between meals? And how much to give? Should we be just replacing the losses that are from dialysis, or should we be supplementing more? How long? I know they give a recommendation for at least 3 months, but many of these studies were much longer than that. And so we are not sure about the optimal duration, and as well how to best monitor the response to the ONS using weight or biomarker outcomes. Okay, and so there is a new emerging study called the HELPS HD trial. And this is a pragmatic cluster randomized trial in which they randomized facilities in which all of their HD patients received a protein-based ONS versus the existing protocol in which only patients with low serum albumin or incident patients at the first 90 days of dialysis receive a protein-based oral nutritional supplement. And the preliminary results that were presented at the ASN Kidney Week last year did not identify a significant difference in mortality. However, this, I believe, has yet to be published. And so that begs the question, who would benefit most from ONS? And it may appear that one size does not fit all, and perhaps we should be applying a more precision nutrition approach. And so this is a topic of research that I'm currently working on. We've done some cluster analysis of biochemical and lab parameters to determine different phenotypes of patients and looked at their response to oral nutritional supplements over time. And it does appear that there are different responses to oral nutritional supplements depending on the phenotype of patient. And that's a current area of research. And so this other guideline here was published back in 2013, but I do want to show this to you. It's from the International Society of Renal Nutrition and Metabolism. And they outline an algorithm here for screening and assessment, as well as what preventative measures to institute. This might include optimizing the dialysis therapy and the nutrient intake, and managing the comorbidities such as acidosis as sort of a preventative measure to improve nutritional status. And then the indications for nutritional interventions that they list here are the ones that they recommended. And this includes poor intake, low serum albumin, unintentional weight loss, subjective global assessment in the PEW range, or worsening lab markers over time. And they also give some recommendations about the maintenance nutritional therapy goals of what we should be aiming for with with our treatments with oral nutritional supplementation. Okay, and just to give you an idea of our nutritional supplement policy in British Columbia, so we have a policy that's stewarded by the registered renal dietitians in our province. There's no EGFR restriction, and ONS prescription is based on a nutritional assessment by the renal dietitians. And the indications for starting ONS include unintentional weight loss more than 10% of the usual body weight in the past 6 months, current weight less than 90% of desirable body weight, nutrient intake less than 80% recommended, or hypercatabolic state. And the duration of the supplement is variable depending on the patient's underlying medical condition, their nutritional status when they started the supplementation, their response, and the time it takes for them to eat adequately. So this really relies on the reassessment by the dietitians. And that's also indicated in the policy there. And in our province, the renal dietitian is solely responsible for ordering and determining the duration of oral nutritional supplements for patients. I note that in other jurisdictions, like in the US, the policy for oral nutritional supplementation is based solely on albumin levels. And so our approach is a bit different, and it highly relies on the expertise of the dietitians. I'm just going to touch briefly on enteral tube feeding. So if oral intake itself is not adequate, there are strategies for enteral tube feeding, which might include a nasogastric tube or a G-tube or a jejunostomate tube. Okay, and so the recommendation here is that for patients with CKD 1 through 5D with chronically inadequate intake and whose protein energy requirements cannot be attained by dietary counseling and oral nutritional supplements, it's reasonable to consider a trial of enteral tube feeding. And it does require a collaborative effort between the patient, caregiver, and unit staff. They encourage you to schedule feedings around travel and dialysis treatment times so that their provision of the feeding doesn't get cut short because they have traveled to dialysis. And they're often advised to continue oral intake if tolerated. They have to be mindful about minimizing tubing flushes because that can increase the risk of fluid overload. And again, those renal specific formulas, which are energy dense and low electrolyte, are often available as both oral and as tube feeding versions. So this can help prevent fluid overload and electrolyte problems. I'm going to touch briefly as well on intradialytic parenteral nutrition. And so their guideline on TPN or IDPN is graded as 2C here, but it basically can improve and maintain nutritional status if nutritional requirements cannot be met with existing oral and enteral intake. Okay, and so IDPN is the provision of nutrients through the venous drip chamber during hemodialysis, and it includes an infusion of amino acids, dextrose, and lipids. It can provide about 1,000 kilocalories and at least 50 grams of protein per treatment. The volume of the IDPN must be added to the amount of fluid that is to be removed that day. So if a patient has a particularly high intradialytic weight gain for that dialysis run, you may have to reconsider if you can safely give IDPN for that run. In terms of the supporting evidence for IDPN, there was one randomized trial that did not find a significant association between IDPN use on mortality and hospitalization. However, their comparator this was a study that looked at IDPN plus oral nutritional supplements and compared it to oral nutritional supplements alone. And in terms of anthropometric measures, IDPN does increase BMI, dry weight, skin fold measurements. However, for BMI, in the study that compared IDPN plus oral nutritional supplements versus ONS alone, they noted that there was a similar improvement in BMI over time, and because comparable protein and energy were given to the patients in both groups. And there were 3 studies looking at IDPN and laboratory markers, and it did increase albumin and pre-albumin, as well as transferrin levels. They did not find any effect on CRP or hemoglobin or lipid profile. And 2 studies here looked at the effect on energy and protein intake, and these showed inconclusive effects there. This is the large clinical trial here that compared IDPN plus ONS versus ONS alone, and it did not show any significant difference in mortality. But we note that both groups had increased BMI, serum albumin, and prealbumin. So their rationale for their conclusion is that perhaps it doesn't matter which route you give the supplementation, whether through IDPN or ONS, they still benefit from, in terms of having a higher BMI, albumin, and prealbumin. There was no difference in hospitalizations or functional index. So this is an overview of the evidence for IDPN and hemodialysis. And it just summarizes everything from the past couple of slides there. And as noted, most assessed anthropometric measurements, and there were similar benefits seen with both oral nutritional supplements and IDPN. These are just some of the implementation considerations here for IDPN. There is a higher risk of infectious complications, and the cost is a major barrier for regular use. The patients who might benefit from this include patients with evidence of protein energy wasting and inability to administer or tolerate adequate oral nutrition, and that the IDPN can help them meet their protein energy requirements. However, it is not considered a long-term approach, and if they cannot achieve their requirements through IDPN or the gastrointestinal tract is impaired, TPN given daily should be considered. Now in British Columbia, you have to have at least 50% of your estimated nutritional requirements by oral intake, because IDPN would not be able to provide enough intake to meet requirements if the patient can't meet at least 50% of their requirements by oral intake. So as mentioned, IDPN is more of a temporary and adjunct therapy, and patients should be monitored for intolerance, such as nausea, vomiting, diarrhea, and blood chemistry monitoring is warranted, and the tests that I've listed there are the things that we would check for in our province according to our policy. And I'm just going to touch briefly on intraperitoneal amino acid supplementation. And so essentially in PD, in particular, protein energy wasting can occur because there is a loss of amino acids and protein into the dialysate, and this is quite significant loss. Insulin resistance is also an issue among people with on peritoneal dialysis. So there is a commercial product called Nutritional, which is a PD solution that has 1.1% amino acids plus electrolytes. It has an osmotic gradient similar to 1.5% dextrose solution. And the potential benefit of this is that it can increase the net intake of amino acids. So you can absorb about 16 grams of amino acids in a 6-hour dwell, and you would basically replace one of the dextrose bags with a Nutritional bag per day, like one exchange per day. And it's thought that amino acids are not as damaging to the peritoneal membrane as dextrose, and that you can reduce the infused carbohydrate load and therefore decrease incidence of hyperglycemia and hypertriglyceridemia. So they do not actually suggest substituting conventional dextrose dialysate with amino acid dialysate as a general strategy to improve nutritional status, but they do say that it is reasonable to consider it if nutritional requirements cannot be met with existing oral and enteral intake. And this is an opinion, so not strong evidence. When we look at the supporting evidence, there are 3 studies, 2 RCTs, 1 non-randomized study, and they did not find any effect on anthropometric measures, including mid-arm muscle circumference, arm circumference, and no effect on serum albumin, prealbumin, transferrin, and there was no effect on total protein or energy intakes. The IPAA can decrease bicarbonate levels though, so that's actually something to watch out for in terms of acidosis, but it can be readily treated. So we see here the evidence for the intraperitoneal amino acid supplementation here is weaker. A lot of the studies did not find any improvements in the surrogate outcomes. We do have 1 clinical trial that did look at mortality and hospitalizations, but there was no significant effect of the IPAA on those outcomes. Hence, the guideline is really just an opinion. Okay, as mentioned, for implementation considerations, IPAA can cause acidosis, so that's something to monitor for. However, it can be useful for treating uncontrolled hyperglycemia. And as mentioned at the bottom here, IPAA should only be used if spontaneous protein energy intakes are able to be met in conjunction with IPAA to meet the required total intake targets. Otherwise, if that doesn't, that's not sufficient, TPN or partial parenteral nutrition should be considered. Our monthly lab monitoring for patients would include albumin, bicarbonate, and glucose for these patients. All right, so I'm just gonna wrap up here with the summary because I know we covered a lot and I'm happy to answer your questions as well. But essentially, nutritional screening should happen at least biannually, but our renal dietitians often do this more frequently. Comprehensive nutritional assessments by renal dietitians should happen at least within 90 days of dialysis initiation, but ideally earlier, as well as annually or when indicated. They note that best practice would be a biannual routine assessment. And then the progression of nutritional interventions, you always start with nutritional counseling and then move upwards as needed in order to meet the intake requirements. And then ONS for treatment of protein energy wasting demonstrated benefit in biochemical weight and body composition parameters, but the effects on clinical outcomes such as mortality, hospitalization, and quality of life have not been well established due to underpowered studies. And we need more research to identify information about the specifics of ONS therapy, including who would benefit most, how much, how long, and how to monitor. And next, IDPN improves biochemical weight and body composition parameters, but there is a paucity of clinical outcome studies. And it's important to note that IDPN does not provide complete nutrition. It is temporary and it is an adjunct to nutritional counseling and ONS. And IPAA amino acid supplementation is not recommended as a general strategy to improve nutritional status, but can be considered if the nutritional requirements can't be met with counseling and oral or enteral intake. And it is important to involve a multidisciplinary team in managing protein energy wasting. And it's also important to incorporate patient values into developing the nutrition management plan. I've left my contact information here, and I'm happy to take any questions.
Wow, Michelle, that was an excellent presentation, great presentation. Thank you very much. So we are going to the second session for questions and answers. I think you'll be ready to answer the questions and comments, Dr. Wang. Yeah, so maybe I should start. Michelle, the comprehensive nutrition assessment that you say should be done at least within 90 days after dialysis initiation, and then annually, and or whenever is required. So I think I was thinking that 1 year to be done annually in patients with dialysis, that duration is too long because, you know, example in Africa where, you know, the food is scarce, most of our patients are poor. I think it should be maybe be done within 1 monthly or 3 monthly, rather than waiting until 1 year.
Yeah, so, exactly.
Yeah.
So these are what the guidelines mention as sort of minimum requirements. So I would agree with you, and the International Society of Renal Nutrition and Metabolism, they also say monthly or every 3 months for sort of nutritional screening. And I would say in practice, the dietitians are monitoring our patients much more frequently than what they recommended in this guideline. So I would agree with you, and it does seem more appropriate that like for hemodialysis patients in particular, monthly, along with the monthly blood work that's done, is a good rule that a lot of dietitians do follow. But it can be individualized. There are some patients who are probably much more stable, or who do not have a lot of risk factors for protein energy wasting, who might be able to be followed less frequently.
All right, thank you. So we will hear some comments from the audience. Any other question or comment? I would like to hear from Dr. Jonathan, Elliot. I've seen Elliot, you have joined, your experience from Ghana, and, you know, from anyone.
Yeah, Elliot here. Maybe I'll just take a bite.
Yes, Elliot.
Yeah, so fantastic presentation. I mean, we've had some discussions, and you know how important nutrition is for most of our patients. So I think you've laid it very clear for us in terms of understanding. But a very quick one. Like it was mentioned, in fact, we have our peculiar challenges where your average dialysis patient is so malnourished. And in fact, they virtually are malnourished before they get onto dialysis, and they are even worse with all catheterization, chronic inflammation, and so on and so forth. So you actually find yourself in a situation where you virtually never get them optimum in terms of nutrition, until sometimes they pass on, and the few who are able to actually get onto transplant and all. So I want to be clear, what would you advise, I mean, for us? And like most of the things you also talk about are not available. What do you think we can generally do that is practical, that is probably not too expensive for our already burdened patients to ensure that we have the best of, you know, their quality of life? Michelle.
Yeah, thanks. That's a very good question. And I think that there are probably a few things. I guess, first of all, I am working with the ISN and the International Society of Renal Nutrition and Metabolism to help develop some educational resources for specifically nutritional management in low and middle income countries. So that is something that I hope to be working on specifically to develop some resources with local expertise. And so I would say it is important probably to make sure that we have an adequate workforce in terms of renal dietitians. And there are a lot of specific things about nutritional management in the kidney population, which are very specific to our population. And so I think it is important to have a renal dietitian. And I work with them very closely in my in research and in clinical practice here. And so I really do rely on their expertise. And I think the first step that they can do is really the nutritional counseling. So I cannot overemphasize that you should always start with that. I think, you know, working with the dietitian can find ways to try to optimize their nutritional intake with the, you know, in the context of the patient's daily life. And in terms of oral nutritional supplementations, I know that a lot of these commercial products might not be available in East Africa. And so I think perhaps there's alternative oral nutritional supplements that can be made with an ingredient list, actually. And so that's something I just took from one of the studies from Brazil, and they just gave instructions about how to make something with eggs and milk and other ingredients that they've put together. So I think there may be ways of getting around that if commercial products aren't available. But I also think it's good to advocate for patients to see if you know, funding can be obtained for commercial supplements as well, because they can be they're the next line for treatment and prevention of protein energy wasting.
All right, thank you. If there's any other question or comment, I've seen someone who has raised the hand, but I can't recognize his name. Can you please go ahead and ask?
Yeah, so sure. So this is regarding Makwabe. This is regarding.
Oh, thank you, Dr. Pasco, for joining. I think you are going to give us your experience in Tanzania, because you have recently published papers regarding nutrition in dialysis in Tanzania. Please.
Thank you so much, Dr. Makwabe. Thanks a lot to Michelle. Actually, for the past 1 hour, my wife and I, both nephrologists, have been spellbound by a scintillating lecture from Michelle. Very practical insights, and the guideline is really ready to use. So I am equally excited by the fact that she cited 2 papers from Tanzania, from our local research group here, led by our recently graduated physician, Dr. Puniti Brahmania, on dialysis, which is very high at 62% using FDA, and MIC, malnutrition inflammation complex, which is almost 46.3. So I was actually appealing to Michelle that probably our publications came a little bit later before the guideline was out. If she can incorporate our publications, because the level of evidence using FDA, as she said, was 1B, which is very strong. So that in the future update of the guidelines, our publications will be deservedly cited. That will be very good favor from her. So my question was, in fact, BMI is increasingly becoming, she pointed out about the chronicity index. And I felt like the chronicity index could be a good surrogate, probably more practical, easily accessible at the bedside. So what is her experience? What is the level of evidence, and how can it be quickly performed to assess the nutrition status, especially for patients on hemodialysis? Thank you.
Right. Sorry, I think the audio sort of cut out briefly during your question here. But I think you were asking about, for example, the chronicity index in terms of best ways to measure nutritional status in HD.
Yes.
Yeah. Yeah. So I think you need to look at the constellation of several nutritional parameters in order to get an idea of the nutritional status. In particular for HD patients, rather than just the BMI or just the target weight, it's probably better to look at the change over time. So we know that more than 10% weight loss over 6 months is definitely a red flag for possible protein energy wasting. And so that's also one of the criteria that we use to give oral nutritional supplements in our policy. So I think the weight change is a very important parameter to follow. I think as well, because hemodialysis patients do have a lot of frequent lab monitoring, that you can look at things like serum albumin, or inflammation markers. You can calculate the protein catabolic rate with the monthly lab work. So those are all things that can be incorporated into the nutritional assessment as part of routine care. And the chronicity index that you bring up is interesting. I haven't quite used it myself in practice, but it can be calculated using weight circumference. And this index has been used in clinical studies. It has been shown that high chronicity index is associated with higher risk of death, hospitalizations, and higher inflammation markers. So I think it is good to try to identify patients who might have low muscle mass despite having high adiposity. So BMI, as you mentioned, does not give the full picture. So, but I think these are relatively easy to measure parameters that can be incorporated into practice.
Thank you, Michelle. Yes.
Dr. Makwabe, just really quickly, if possible, I want to thank Michelle for the time, but also make a quick plug for the ISN Emerging Leaders Program. Many of the individuals on this call are part of Michelle's cohort, including Dr. Elliott from Ghana, Dr. Robert from Uganda, Dr. Iqbal from Indonesia joined. And I would highly encourage nephrologists who have joined these calls to explore this program for next year's cohort, as I think it creates a really amazing network and opportunity to draw experiences globally. So hopefully members of this call next year will be in 2022's cohort, because if it wasn't for that, we wouldn't have had the opportunity to have Michelle on the call today. So thank you, Michelle.
Thank you,
My
Nick.
pleasure.
Thank you, Nick. It's a very good comment. Yeah, so can we go to the chat box? And Michelle, can you go through quickly on the chat box and then just respond to a few questions?
Yeah, sure. Now I see a question from Dr. Bermania here about how do we target to reduce inflammation implicated in protein energy wasting? And so that's an interesting question. I think that, so obviously if there is an underlying specific cause of inflammation that can be addressed, whether it's an infection or whether it's a dialysis catheter or something like that, obviously we'd like to address if there is a specific known cause. But the interesting and reassuring thing is that patients with inflammation still respond to oral nutritional supplementation, as well as perhaps even better than patients without significant inflammation. So I think that was shown in some observational studies, as well as some of my preliminary research as well in the non-dialysis population. So I think that if you can have access to things like oral nutritional supplementation, that can still be beneficial in patients who have significant inflammation. There's also a question here. When do we recommend to check electrolytes in patients on HD or PD in order to modify their diet? I think this can be incorporated with their usual lab work that they're having done anyways. And often these patients, hemodialysis patients, will have blood work in our unit every 4 to 6 weeks. So I think using these lab parameters, or dietitians using these lab parameters that are used or that are drawn anyways with routine practice, I think is sufficient. Like, I don't think they need extra monitoring on top of what is already being done for the patients. Okay, and I think Dr. Vincent had a question here: in the absence of inflammation, adequate dietary intake. So assuming there is adequate dietary intake and absence of inflammation, what would be the recommended albumin range in a dialysis unit? So I don't know if I have a specific answer to that, but usually when they're targeting treatment with oral nutritional supplementation, they do like to see a serum albumin of 40. For example, in the US, they want to have a sustained normal albumin for 3 months at least after treatment with oral nutritional supplementation before they decide to stop the supplement. So I think, yeah, either above 38 grams per liter or above 40 grams per liter are some of the cutoffs that some policies have used to determine when to stop oral nutritional supplements. And that would probably be the ideal serum albumin. But I do note that the guidelines try to de-emphasize using serum albumin alone as a nutritional marker, and they would, even though it's very highly correlated with hospitalization and mortality, they emphasize looking at the complete picture with all the other nutritional parameters.
Thank you so much, Michelle, for a wonderful presentation. Thank you very much.
Thank you.
All right. Yeah, you proceed.
I realize
please,
there's more
Michelle.
questions, but would you like me to? I'm happy to try to address these other questions either through email.
Exactly. Yeah, you can just take on one more question in the chat box, and then we finish.
Okay. Okay, so there's a question here. In order for a patient to gain weight or muscle protein, protein is required. For dialysis patients, we encourage a high protein diet. How can we prevent further kidney damage without compromising the nutrition quality? And I'm not quite sure about this question. Is it more that a high protein diet, so obviously we wouldn't recommend that in someone not on dialysis, but I think that certainly once patients are on dialysis, the catabolic process of dialysis is great, and the protein losses through dialysis are much greater. So therefore, the requirements for protein are much greater, and so I think that's just the guidelines reflect that the intake of protein has to make up for those losses. And so I think there's less of an emphasis on preventing further kidney damage when the patient's on like a chronic dialysis patient, I think at that point, in terms of the diet is really there to help maintain their nutritional status. I think that's the main focus, rather than specifically on using the diet to help with maintaining residual kidney function.
All right. Thank you, Michelle. It has been an exciting presentation. We really appreciate for your time. And also, I would like to thank everyone who attended. The attendance was very good from all over Africa and outside Africa. So we really appreciate everyone who has attended and for your active participation. So we have come to an end of today's presentation. And special thanks to Michelle. And also special thanks to AHN, Nick, Lloyd for all the hard work that you have done to bring Michelle into today's presentation. So thank you very much. So we'll see you next week on Thursday. Thank you. Goodbye.
Thanks for having me.
All right.
Thank you so much. Thank you very much for taking the trouble to come out here. Extremely.
I'm happy to be here, and I have saved the chat. So
okay, bye-bye, Michelle.
Bye now. I'm happy to respond to those questions separately.
All right, thank you. Thank you very much.